Okay, so now let's move on to talk about how we measure acoustic reflexes. So again, we're looking at the middle ear space, and we're looking specifically at the malleus and incus and the stapes. And we know that when the stapedius muscle contracts, and the stapedius muscle isn't shown here, but when the stapedius muscle contracts, it pulls the stapes backwards. It essentially pulls the stapes slightly out of alignment, and it's going to cause what is essentially stiffening of the ossicular chain. And that we can't measure. But when the ossicular chain becomes stiffer, the tympanic membrane becomes stiffer and less compliant, and that we can measure. So we measure the reflex, but we measure it indirectly. We're measuring the reflex through a change in compliance of the eardrum. And it's important to remember that it is an indirect measurement, that we're measuring the reflex, but we're actually not measuring it directly. So, just to review, we're looking at the stapedius muscle, the cochlea, the auditory nerve, and then brain stem structures like the cochlear nucleus, the SOC, and the facial nerve nucleus, and then cranial nerve 7, which is the facial nerve, and cranial nerve 8, which is the auditory nerve. And then we're also looking at those same structures on the other side of the head as well. So we measure the acoustic reflex using TIMPs. And the way that it works is that we hold the tympanic membrane at the so wherever at the pressure that it vibrates the easiest. And then we introduce a sudden, very intense sound and measure any decrease in compliance that happens as a result. So essentially we hold the TM at its most compliant and then try to evoke the reflex and measure the stiffening of the TM in response. It's done through the emittance machine. So this is all sort of done automatically in terms of the tympanometer is going to find the spot, the pressure for peak compliance through tympanometry, and then hold it there and then introduce a sudden sound when you present intensity. And then the tympanometer is also going to measure and chart compliance as you push the stimulus buttons. So the next question is what's a response? What counts as a response? So a reflex has a threshold, and then once the threshold is surpassed, the reflex grows. A threshold measurement of 0.02 or 0.03 counts as a present reflex, and you should check for growth if you're unsure. So as an example, if you test the reflex at 80, if you present a sound at 80 dB and you measure the reflex and you get a 0.02, but you're not completely sure if it was, if they were just breathing or swallowing or if it's really a reflex. If you go up from 80 to 85 and it was a true reflex, the reflex should grow. From threshold at 80 of 0.02, the reflex itself should grow to 0.03 or 0.05 or 0.06 as you get louder. And I'll show you some samples. The morphology also has to be there. What you're looking for is a change on the graph. It looks like a dip in compliance that isn't artifact, and they have a particular look. Sometimes if somebody swallows or pops their ears during this, you'll see a dip, but it's not, it doesn't look like a reflex. Typically, we measure acoustic reflexes at 500, 1,000, and 2,000 hertz. There is the option on most tympanometers to measure at 4,000 hertz, but the variability is much higher at that frequency, and so it's not used all that often. You have the option of stimulus levels ranging from 80 all the way up to 110 or 115 dB to try and evoke the reflex. And then you have different outcomes, and we'll talk about what these mean in a moment. You have ipsilateral right, ipsilateral left, contralateral right, and contralateral left reflexes. And typically you look at them as a set. So you're looking less at individual reflexes and more the overall pattern for these 4 different categories. Are the reflexes present at levels that would be normal? Are they absent or elevated? You're essentially looking for a normal or abnormal outcome. The ipsilateral reflex is when the sound is introduced into the ear and the reflex is measured in that same ear. So you put the sound in the left ear, and the probe measuring the reflex is also in the left ear. So here we have the sound via the little yellow explosion, and the probe, the red probe, are both in the same ear. So you're just measuring this ipsilateral pathway here. You're not measuring any of the crossover to the other side of the head when you get an ipsilateral response. In a contralateral reflex, you're introducing the sound in one ear and measuring the reflex in the opposite ear. So what you're actually looking at is you have the sound going into the left ear, but the probe is in the right ear measuring the right reflex. There's been some controversy or debate over how to do this in the last 10 years, how to label the conditions. This is taken from both your book and then also from the recent Lisa Hunter book all about tympanometry. This is the terminology you're going to use. The probe ear is where you're measuring the reflex. The activator ear is where you're presenting the sound. So, a right contralateral reflex is a stimulus right ear measuring left ear. A left contralateral reflex is stimulus left, probe right. And then left ipsilateral and right ipsilateral are easy to remember. And when you go to different offices and different clinical placements, you're going to see this written out many different ways on different audiograms. If it helps, and sometimes it helps me terminology-wise, if you think about it as, or if you use language in a report saying the reflex, the left ear contralateral reflex is the same as saying the reflex contralateral to the left ear, or even saying reflex contralateral to left ear stimulation. So when we're talking about patterns, left ear contralateral means the stimulus went in the left ear and the probe was measuring the reflex in the right. Be sure you're straight on those. Some important things for testing about measuring the acoustic reflex. For the acoustic reflex testing to work, you have to be able to maintain a seal without holding the probe. You can't hold the probe for acoustic reflexes because any small movement of your hand is going to change the reflex. So you have to be able to maintain a seal. For whatever reason, there are some people who you just can't get a seal to take and hold. And then you just make a note, could not maintain seal. You can't measure acoustic reflexes with a type B temp. And you should figure out why not. Think about it a little bit, but we can talk about this in class. There's a reason you can't measure ARs when you have a type B temp in that ear. The other thing to know, stimulus levels are intense. They go all the way up to 110 or 115 dB. Because of this, there may be clinic-specific limits. So you may be at a placement and they might say, we just don't test over 105 dB. We're not comfortable, it's too loud, we don't like to expose our patients to that. Or you might have an issue with patient tolerance. The patient might jump, or they might, sort of jerk their head away and say, no, that's too loud. So there are some issues there to be aware of. So clinically, to measure an acoustic reflex, you're always going to do temps first to be sure that temps are normal. And then if acoustic reflexes are needed, you're going to do a threshold search. So you'll see them called ARTs, acoustic reflex thresholds. Again, the threshold is what you're measuring and what you're writing down on the audiogram. If you want to obtain acoustic reflex thresholds, you're going to do a threshold search for threshold at 500, 1000, 2000 hertz, ipsilaterally, and then contralaterally for each ear, starting at 80 dB, and then you increase the intensity by 5 dB until you find threshold or threshold plus 5. And then you record the threshold. Either you print it out or you write it down on the audiogram. And then you move on to the next frequency. Just as a side note, the screening temp also has the capacity to do a screening reflex test. And we all listened to that last week. That does, I think it does 85, 90, and 95. And just records whether or not a change in compliance is noted. And you get either a yes or a no to the acoustic reflex. And that's just a screening test for the reflex.